All right, so we're going to start now, guys. If people do come through, our other executives will add them as they come along to the waiting room. First of all, everybody, welcome to the first sessional that we are hosting, which is an evening with. It is going to be a recurring segment which will, bi-weekly, we'll be introducing nurses to the society as well as to nurses in general, where we hope to actually just provide the opportunity for students to actually understand what it's like to work as a nurse in specific areas, such as areas like forensic care today, all the way through to pediatric nursing, or to be a safe injection clinic nurse as well. My name is Frankie. I'm the president of the Victoria University Student Nursing Association. We do have a few other executives here as well who will be moderating the chat throughout the entirety of the day. And with us as well, any questions, it is going to be very laid back, so just type in the chat and we can unmute you should we want you to expand on the question or you want to have that conversation and dialogue as well. We will just go over some brief housekeeping rules. Just for the time being, so most of you guys when you joined will be muted. We just say throughout the presentation just to keep it muted, and we will unmute you if we need you to expand on a question or if you have a question to ask as well. Zoom does have the raise hand function, so you can raise your hand, type a question, and we just have that sort of prompt to kind of get us going. This is going to be a recorded event, so we are recording this so we can upload it to YouTube so people can look at it for future reference, or in case a friend of yours couldn't see it, you can access it at a later time, essentially. If I am talking too fast as well, there is also the option to press go slower, so that's something you guys can all take into consideration. Again, if you have a question you'd like answered at the end of the session for the live Q&A, type it out into the chat and we'll get through as many as we can. And just basics, guys, just be respectful to those around, no foul language. And again, we'll be providing links on our Facebook and Instagram to the link where you can access these. Now, without wasting any more time, we do have our special guest here today, which is Daniel Duda, who is not only a close friend of mine, but also a nursing mentor for many. Daniel, would you like to introduce yourself for everybody?
Yeah, so my name is Daniel. I'm I guess I'm a registered nurse. I work over at Forensicare. So I started working for Forensicare in 2014 at the start there, straight after I finished uni. I did my grad year there, and Forensicare is a little different to most other hospitals, whereas they offer both a grad year and a post-grad year. So I did 2 years there, and I got a position there and have been working there ever since. I started off in Thomas Embling Hospital, so I worked there for approximately about three years, and then since then I've moved to the women's prison, so Dame Phyllis Frost Centre in Ravenhall. So I'm currently a RPN3, which is about the equivalent of a ANOM, and I work over on the Marmac unit there at Dame Phyllis Frost.
Yeah, so it already sounds like there's going to be some big changes from the prisons to the hospital. So throughout this presentation, Daniel, as well, if you want to talk about any experiences, such as your experiences at the hospital and compare it to the prison as well, feel free to jump in and chime with it with the questions. One of the very first questions we kind of had today as well is how would you describe what it's like to work at Forensicare? So obviously it is you've mentioned just then, it is a big change to other mental health services and it's quite a unique place. So some people here may have had placements there or some people may be interested in a placement. Give us the lowdown. What's Forensicare like?
Well, I guess Forensicare is unique because there's a number of job sites at which you can work at. Because as I mentioned, I worked at both the prison and the hospital. But there's also a number of prison sites you can work at, including Ravenhall and MAP, and also the community team. So there's, I guess, in a sense, it's quite different to a lot of other nursing roles because there is so many different positions you can essentially do as a nurse in the forensic care organization. But for me, I've worked at Thomas Embling Hospital, which is like an inpatient unit, and also currently in the Marmac unit, which again is an inpatient unit, but it's a little bit different to your standard inpatient unit. So what's it like to work at Forensicare? I guess it's very different to your general nurse. If I was to compare it to general nursing, I'd say it's very, very different. Yeah, so it's I guess
Daniel. So Thomas
sorry?
Embling, you've mentioned Thomas Embling Hospital, and you've also
Yeah.
mentioned the prison. So how do they operate in terms of your daily routine, or what are the differences in terms of how you as a nurse approach care?
Yeah, so I was about to say, mental health nursing in general is a lot less task oriented when compared to, I guess, general nursing. So in general nursing, you have, I guess, you have your set kind of daily planner, you go about your day, you know when you have to do your obs, when you have to do your showers by, when your medications are due. Mental health nursing is completely different to that. There's no kind of set routine as to what you're doing. It's a very dynamic kind of workplace. every day is generally different, and it all depends on what's happening on the unit at the time. So in that sense, it's quite a bit different to general nursing. As I said, very much less task oriented, but you utilize a lot of different skills there. So I guess forensic care is mental health nursing in general. You tend to focus more on, I guess, communication and things like that versus your more practical skills like always doing obs and monitoring a patient's vitals and stuff like that. So in that sense, it's very different. In terms of daily routine, as I mentioned, there's no kind of set structure to your day. Like I guess when I walk onto the ward, if I was, for example, starting my day, the first thing I generally do is just have a coffee and sit down with the patients. Oh, that is, of course, after getting handover. But, you just got to get a feel for what's happening on the unit. Whereas I guess if you were in a general ward, you'd be, making sure that you've got your day planned out, all your meds and stuff, when you're doing that sort of thing. So it's different in that sense. It's a lot less, I guess it's chaotic in a sense that you don't know what's going to happen. And that, just leads itself to the nature of mental health nursing.
Yeah, I mean, you said you had a coffee with them as well. How important is the therapeutic relationship when you are, so to expand on it, so what type of consumers or what type of individuals would you actually have at Forensicare, just to expand for those people who might not actually be aware?
So Forensicare is an interesting organisation. So we're the sole provider of mental health care to the forensic population of Victoria. And by forensic population, what I mean is the group of people that have interacted with or are currently in the justice system. So they're either on remand, they've been sentenced, they've been I guess, arrested, or they're currently incarcerated. So we deal with that population.
And so, like, obviously, when you have a coffee, you sit down with these guys, and you've got people who have done probably some horrific things, and people who might be in there for more petty crime, possibly. So when you sit down and have a coffee with them, what are you looking for? I guess is anything in particular?
Oh, not really. I mean, I guess the whole idea behind just going out there and just kind of sitting down on the ward and just taking a step back really is just to observe what's going on, because you kind of plan your day around how the ward, I guess, the milieu of the ward. So you'll hear that in your I guess in your mental health class, the ward milieu, and that essentially refers to, I guess, the feel. That's the best way I can describe it. So you kind of figure out essentially what's going on. Is there any kind of conflict between patients, or is a certain patient deteriorating, things like that. And by going out there and just sitting down, talking to the guys, reading the newspaper with them, drinking a coffee, having a bit of a chat to them, you kind of get a gauge as to what's going on. And then you plan your day around that, because you might have a patient that's deteriorating in terms of their mental state that you can pick up on, and you might have to plan interventions around that, or there might be a conflict between two patients that you need to mediate, and you can get all that from just simply being out on the unit. So that's why it's important to, kind of just go out there and figure out what's going on.
Well, so I understand there's a lot of differences within forensic care as well. So you work at the prisons now at Marmac.
Yeah.
And you also work at Thomas Embling Hospital down in Fairfield. Yeah. In terms of you as a nurse, what is kind of the changes in your role in terms of I understand the prisons are probably running a little bit different. So how is that kind of differed between the two?
Oh yeah, so Thomas Embling is run like an acute mental health unit. So if you've done your mental health placements, I'm sure you've all been, I guess the majority of you would have been on an inpatient unit. So Thomas Embling is very similar to that setting. I guess the key difference is that the general length of stay is a bit longer than in area mental health. So that from moving from there to the prison site, the prisons operate under the Prison Act and are essentially run by the prison officers. So it's different in the sense as your autonomy is kind of taken a little bit away in terms of what you can and can't do, because you have to practice in accordance to the Prison Act and to what the prison officers allow you to do. Because if they deem something too dangerous to do, or if it's not within their policies to do something, then you can't do that, even though it might be the intervention you want to put in place. So it's different in that sense. You kind of have to work around corrections, whereas at Thomas Embling Hospital, you're less restricted in terms of what you can do and what you can implement. So I guess that's the key difference. Also, the prison setting is what we call a non-gazetted service. Because they operate under the Prison Act instead of the Mental Health Act, we can't actually force treatment there. So if you get someone that's quite unwell, you can't forcibly provide them treatment like you can at Thomas Embling, whereas if someone's unwell and refusing treatment, you can actually give them an IM injection or something along those lines even if they're refusing that. Whereas in prison, they have the right to refuse any kind of medical treatment.
And you mentioned the length of stay as well. So, what's your average length of stay? Obviously, the prisons would be based on their sentence, but in terms of like Thomas Embling Hospital, what's kind of like your average stay, or perhaps even enlighten us about what's the longest stay, I guess, that's been experienced?
I guess Thomas Embling's fairly unique because we generally the client population that go to Thomas Embling are either so unwell that we deem them unable to consent to treatment, so therefore they generally refuse in the prison setting, so we send them over there. But they are still on remand, so they're what we call a secure treatment order. So that's one type of patient that you get at Thomas Embling Hospital. Another type is what we call a custodial supervision order. So there's someone who has committed an offence. They've gone through the court system and they were found not guilty via mental impairment. So those are your more known sort of patients that people tend to think of when you think of Thomas Embling Hospital. You know, they've gone out, they've committed some horrendous crime, and then they're found not guilty via mental impairment, but they're sentenced to spend their time at Thomas Embling. So those patients, they get what's called a nominal term. So the judge will say, all right, for murder, you get 25 years nominal, which means they have to receive mental health care for approximately 25 years or be from Forensicare. But in that time, they can progress through Thomas Embling Hospital if they get well enough and are deemed safe enough to go back into the community. They can do. So I would say about the average length of stay, from my experience, is about 5 years in Thomas Embling. If you come to Thomas Embling, you respond well to treatment. It takes roughly about 5, maybe 6 years to go through the system to the point where you can integrate back into the community. I mean, that's not to say that you still aren't on a court order, because generally you're on something called a non-custodial supervision order. So you're not in custody, but you're still being supervised. But,
it's quite a long time, 5 years. You
Yeah,
definitely get to know the patients throughout the entire
Yeah.
time.
But at the same time, it all depends on how their response to treatment, because then you get some patients at the same time that are so unwell that they actually will never be deemed safe enough to go back into society because their risk of reoffending is so high. So it varies. It really depends on how someone responds to treatment.
Well, like I said, that sounds like it's definitely that's definitely what makes it so different from normal nursing, especially mental health nursing, where stays can be quite short or quite long, depending on what it is.
I mean, you can effectively nurse someone for your entire lifetime, really. Like I know of there's one particular patient that was in the forensic mental health system for over 40 years, and that's an entire career for someone. So you can look after the same person for such a long time, and in that time, you tend to build up quite a good therapeutic relationship with them as well, as you can imagine.
Well, that's definitely it's a good description of forensic care. We will go over to the next question, which is, was there a specific reason you chose forensic care over maybe not just general mental health nursing, but just general nursing in general, I guess?
I guess that's an interesting question, because when I studied nursing, I kind of didn't know. Sorry, can you hear me?
Yeah, you're all good.
Yeah, cool. Sorry. Yeah, so when I first started nursing, I didn't quite know what I wanted to do or where I was going with it. I didn't even know if I wanted to continue being a nurse. And I did my placement at Forensicare, and it kind of opened my eyes to mental health nursing. And I found that was something that was for me. I mean, I would recommend mental health nursing to someone that generally finds that they really enjoy talking to their clients, as opposed to just providing the care. Because what I found in general nursing was I was spending a lot more time just doing all my little tasks, and I wasn't able to focus on the patients themselves. I'd sometimes spend my lunch breaks talking to some of the patients that I was looking after. So for someone who really likes, talking and kind of, I guess, having that human interaction regarding their care, that's someone who I'd recommend going into mental health nursing. And that's kind of why I chose mental health nursing, as I prefer to just, have a bit of banter, have a bit of a chat to my clients. And that's really suited, the mental health nursing really suits that kind of person. And not only that, I find mental health itself is a very interesting subject. So, I've had some lived experience in regards to, personal friends having issues with mental health and things like that. So that kind of drove me towards the area as well. So a combination of those two things, not being too interested in general nursing, plus that lived experience, plus, just really like talking to people.
And in terms of, and the main thing that drove you to forensic care was just that placement there, wasn't it?
Yeah. So again, as I said, I really didn't know if I wanted to be a nurse. I was actually thinking of dropping out and becoming an engineer, funnily enough. And that was really until I did my placement at Forensicare. I thought it was fantastic. Just the way it's run, it's completely different to any other placement I did throughout all my rotations. It was really unique, and yeah, it suited my personality. It suited what I wanted to do as a nurse. So I would say, take it with a grain of salt. Even if you're not interested in doing a placement at Forensicare or your mental health placement in general, just go in with a unbiased view, because I think you'll find that it is very different to what you expect, and even the clients will be very different to what you expect.
Yeah, well, honestly, for most people here, I mean, if people wanted, you can put a show of hands, just raise your hands in the chat if you've been interested in mental health. And I mean, that's, I think for most people that are attending here, mental health is, probably what their key focus as well. But again, it's good to know that, even if you aren't interested in it, you could suddenly have that turn of opinion based on a placement. We'll move on to the next question, which was, so what skills do you think are important for those interested in forensic mental health nursing? Maybe just not forensic mental health nursing, but mental health nursing as a whole.
I think communication is the number one skill that I tend to tell my students is, that is the key thing to mental health nursing. You kind of need the gift of the gab, so to speak, because that is your key to de-escalation. That is your key to conflict resolution. That's your key to being able to conduct an MSc effectively, is to have good communication skills and being able to carry a conversation and, ask questions in certain ways and things like that. I mean, so I would definitely say if you're a people's person, you think you're good at talking and holding a conversation, then it's a really important skill to have, and it would be it would really benefit you as a mental health nurse. I guess another area that's another skill you really need is to be able to conduct an accurate risk assessment. Mental health nursing, particularly forensic mental health nursing, is wrought with risk. You think about the client population that we look after; they're generally people who have committed some quite serious crimes a lot of the time, generally violent in nature. And being able to, conduct accurate risk assessments to ascertain someone's risk of violence or even someone's risk of self-harm or suicide and things like that is really important. So I would say it's something you develop over time as a clinician. Like when I definitely first started, I was not good at doing risk assessments at all, so it is a skill that you will pick up over time. And the more kind of mental states you assess and the more people you interview, the more you kind of build your repertoire and you kind of identify, risks, and you become better at identifying risks. So I would say risk assessment, communication. Also, an area that isn't really discussed, I guess, at university, which I find really important for mental health nurses, is being able to identify gray areas. And by what I mean is, like, if you take general nursing, for example, it's very black and white. You either give a medication, you don't give a medication. You either provide treatment or you don't. Whereas mental health nursing, a good mental health nurse is able to identify the gray area and use that to, resolve conflict and resolve, and to help with interactions of things, because at the end of the day, the client population that you look after is human, and you have to treat them as humans. And they might want one thing, and the rules might say you might not be able to provide that thing. For example, I guess a good example of that is at Forensicare on the unit I used to work at. We used to not give out coffees from the staff station just because you'd end up getting people abusing the rule essentially and asking for a coffee every 5 seconds. But sometimes if you see someone struggling and you see that they're really kind of intense and they're struggling with their mental health, they could be ruminating about something, they could be preoccupied, they could be psychotic, just experiencing hallucinations, and they're quite distressed. Instead of that person, if that person comes and asks me for a coffee, of course I'm going to make them one. It's kind of a no-brainer, even though the rules say I shouldn't give them one. I'm going to give him one because that will help alleviate kind of the stress he's going through, and it will prevent an even bigger incident from occurring. Because you kind of have to weigh up the pros and cons of doing it. Giving him a coffee, there's a little consequence to it. Whereas if he was to, start to get preoccupied and paranoid about me because I said, no, I'm not giving you a coffee, and then down the line he goes and assaults me, you kind of weigh up your options. And I'd rather, just bend the rules a little bit and work in that gray area to get this person comfortable, de-escalate them a little bit versus, leave them to ruminate about something and then, have it blow up in your face essentially. So you have to be able to identify those gray areas, and they'll come up time and time again.
I suppose there's that bartering as well. It's just like, you say, okay, well, if I give you this coffee or if I give you this, will you be able to do this for me? I'm assuming that's...
Well, I try not to negotiate as such because I don't do favors. I don't really... Like, even though you do negotiate, like that's the nature of it, I try not to kind of look at it as negotiation. I see it as this person struggling. just give him a damn coffee, you know?
Yeah, no,
just
the human aspect of it, definitely.
yeah, the human aspect of it. This guy's just like, if you put yourself in your shoes, right? You're experiencing hallucinations of you seeing demons or devils. You've got this voice telling you that these people are after you and are going to kill you. You're quite tormented as an individual, and now you've got, all you want is a coffee to just kind of help relax or chill out. And this nurse is there telling you, no, you can't have a coffee because that's the rules. Like you're gonna flip out a little bit. You're gonna escalate in your behavior. So I'd rather avoid that conflict and kind of resolve that by just bending the rules a little bit. But again, on the opposite side, you can't be too lenient. You have to kind of realize when certain behaviors are starting to become a bit abusive towards that, particularly with certain things like personality disorder and whatnot. What you find is that people tend to take advantage of that. So I guess when I talk about gray area, you can either be a bit too strict or you can be too lenient, because you don't want to just be handing out coffees to everyone, because then there's no point to the rule then, and it ends up creating other issues down the line. But it's about being able to, look at the situation, use your own kind of judgment, and then problem solve you doing that. So that's what I mean by gray areas, effectively.
Well, I think those three, between risk assessment, the conflict resolution, and operating within the grey areas, those are three pretty big important skills. And like you said, it's something that most students will develop over time. It's not like some sort of innate thing.
It's not really taught. And the thing about what I tend to find is when I have students on placements, they're quite concrete about what they can and can't do, what they can and can't say. And unfortunately, the world doesn't really work like that. And it doesn't really work in the setting. I think a good example I've gone through with yourself, actually, Frankie, was let's say you get a client come up to you, and this is more to do with what's it called, open disclosure. What can you disclose, for example? And I believe you said to me that you tell them that, no, sorry, I can't disclose that.
Yeah, so initial thing. So like, to give context for everybody as well. So Daniel and I are close friends, and the scenario that he gave me was a person comes up to me, wants to know my age, and the policies and procedures of the hospital is, you don't disclose personal information.
Even for your uni, you're not supposed to disclose personal information. Yeah.
So like, the way I originally approached to it was to say, look, I wouldn't. I can't do that because of the policies and procedures say that I can't. But when you reflect on that answer as well, and Duda will expand onto why as well. Daniel will expand as to why. It's important. It's about that therapeutic relationship. So Daniel, my answer was, when I first said, if I had a patient come up to me and say, "What is your age, Frankie?" I would say, originally it's like, "Hey, look, I can't tell you that. I'm sorry." But the grey area answer would be, Daniel, if you want to go back.
Yeah, I think by saying it, by giving a answer like that, what you tend to do is as Sherry pointed out, it's too abrupt and you put it back on them. What you're essentially doing is you're closing off the conversation, and what you're doing is you're not leading it. You need to lead with open-ended questions. So I tend to be non-specific when I answer a question like that. If someone says, "Oh, where are you from?" I generally say, "Oh yeah, I'm from Melbourne." It's very difficult to identify where from Melbourne. And, if they tend to push a bit more, then you can say, well, look, that's a bit inappropriate. But, by shutting them down immediately, what you're doing is you're closing off the conversation. So let's say you go and you need to ask them something later down the line. They'll just do the exact same thing to you. And that's happened to me before, whereas I've said, look, I can't tell you that. And then later down the line, I've needed to actually have a conversation with them about something. They didn't want to interact with me because, they thought
the procedures.
Yeah, they thought I was an asshole, essentially,
Yeah. And I think that's a really good way to kind of, think about those sort of things as well. And it goes back into the reflective practice that a lot of nurses students are pretty much told from the get-go.
Yeah.
We will move on to the next question, Daniel, as well. So obviously you work at Forensicare. So what are the biggest challenges you face when dealing with individuals under your care?
Yeah, I guess with this question, one of the things that I find that most people tend to ask or talk about is, they look at the client population that we care for, and they've generally done, quite serious things. They've committed offenses such as murder, arson, rape, things like that, attempted murder. And a lot of people tend to say that, oh, how can you possibly look after someone like that who's done such a terrible thing? And I guess that's one of the challenges that you do face, is a bit of that stigma. And the way I tend to look at it is these people that they were so unwell when they've committed their offense generally, that it wasn't so it was their illness. It was because of their illness that they've committed this offense. It wasn't because they no, not necessarily the individual. And I guess it's a bit difficult for people to process. Like, how can it was, of course, it was the individual that has committed the offense, but to me, you kind of look at it from a mental health perspective. Their mental illness was influencing their decision at the time, and that's what you kind of have to think about when you do care for these people, because I've looked after people, some pretty high profile people that have definitely been in the media, and you hear comments about, oh, these guys are scumbags, how can they do that? And the reality is, they were very unwell when they committed their offense. And once you provide them with a little bit of treatment and a little bit of time, and once you see them respond to treatment, you realize that they're just a normal person that's unfortunately afflicted by mental illness. So that stigma that comes with mental health and for offending as well, so they've got this dual stigma going on. So that's generally a massive challenge that you face when caring for these people. But I guess another massive challenge that you do face is also you see quite a lot of confronting things as a mental health nurse and as a forensic mental health nurse, because you deal with a lot of certain behaviors. And that just comes, unfortunately, with the client group that you look after. So if you look at the statistics in terms of propensity for violence and self-harm and things like that, you'll find that, this client group is just is over kind of exposed, I guess. There's and dealing with that and processing that as yourself as a nurse, but also dealing with those challenging behaviors is very tough. It's very tough. So I would say, the behaviors themselves.
Yeah, no, great as well. And like in terms of challenges as you as a nurse, so is that stigma is the biggest hurdle trying to move forward in terms of providing care, isn't it?
Yeah, stigma's massive, and unfortunately, people's perspectives. I would say if you do get a placement at Forensicare, go in with an open mind. You'll find these. You might see someone that you've seen on the news, or you might look after someone that's done some absolutely terrible things. But what you'll find just by having a conversation with them is they're a normal person for the most part, especially if they've been complying with their treatment. They might come in quite psychotic and they might come in unwell, but seeing that transformation from this individual that was really unwell to someone that's quite coherent and could just be an ordinary person is pretty amazing. And I think that shocks what most students really, they expect these monsters and cages essentially when they come into the prison setting or Thomas Embling, but when they're greeted by what's effectively a normal person, it really does send them for a bit of a loop because they don't expect it.
Maybe that's the most confronting thing as well. That shock that it's just, these are people after all. We
Yeah,
will
I
move on
mean,
to the. Oh, sorry.
yeah, no, I was just going to say, yeah, they're just people, and if you treat them like people, they'll give you the same respect as or if you treat them respectfully, they'll reciprocate that.
We will move on to the next question as well. And I just again, guys, we are keeping track of questions that are in the chat, and we're just making a note of them as well, which we will address at the end of our session. So the next question is, how do you overcome the hurdle of providing quality care to those who may have committed serious crimes?
As I said earlier, it's all about just the mindset. So I tend to, as I mentioned, I just tend to look at the individual and look at the person. At the time they committed their offence, they were generally very unwell. This is speaking more for the custodial supervision orders as people found not guilty by mental impairment. They were generally very unwell. So I tend to just, think about that. They had this illness. Yes, they may have committed this really terrible crime, but that person was unwell when they did that, and my job is to treat that illness, and that's the approach I take. Yeah. You don't personalize it. You don't kind of single out the individual. You just say this is an unwell person, they need treatment, and you provide that treatment. You kind of in a way you don't so much block out their offense, or you don't think about their offense, because their offense tends to lead to their risk profile. But you always have to remember that. But at the same time, you can't hold them accountable for that, because that's not your job. You're not the judge. Your job's to provide quality mental health care, and you just have to remind yourself of that sometimes, because sometimes you do get a bit carried away, and you tend to judge prematurely.
Yeah, we'll move on to our next question as well. So, have there been any experiences where you've been worried about your own safety or colleagues, and how did you cope with that? Maybe talk about preventative measures.
Yes. So, working at Thomas, I would say this is more specific to Thomas Embling than it is in the jail, because in the jail, you tend to have a lot of safety nets for staff members. As I said, the prison's essentially run by the Corrections Victoria, and the correction staff have a handle in terms of risk. So you tend to So you tend to not be put in as many risky situations, because a lot of the time the correction staff will do that risk assessment for you and deem whether or not you can, for example, sit in an interview room with someone. And if they think it's a bit unsafe, they'll place corrections officers to intervene if they need to. Whereas at Thomas Embling, it's up to you to determine a level of risk. And if you're happy to sit down with someone in an interview room that might become violent or might escalate. So yeah, there are many times when I've been worried about my own safety or my colleagues, and that tends to happen when you have an escalating patient. So after my grad year, I worked 2 years in male acute. And during that time in male acute, I looked after some really unwell patients, and for whatever reason, it could be because they're paranoid about someone, a member of staff, another co-patient, or they could be psychotic, delusional, thinking that something's going to happen to them, that people are targeting them. For whatever reason, they've escalated in behavior. And at that time, because it is male acute, you're dealing with someone that can potentially cause great harm to you if you're not too careful. So that's where you employ your strategies, like your de-escalation, and you kind of you try to work with that client and try to de-escalate them to a point where they're no longer a risk, or they might need some medication to help them calm down a little bit. So you try to convince them and de-escalate them, and say, hey, look, you do need a little bit of treatment just to help you, because I can see you struggling, things like that. So that's generally how I deal with it. But how do I cope with that as well? It's a bit hard. Like, no one comes to work wanting to be assaulted. I've been assaulted a few times at my time at Thomas Embling. I think of 3 times I've been physically assaulted, and you get verbally assaulted on a daily, if not weekly basis. Something along those lines. So it does take a toll on you, and it's really important to do some reflective practice and think about what you're doing right, what you're doing wrong, and how can you improve your practice. And that's generally how I deal with it. Have you debrief with your team, with your supervisors, and things like that.
A question that might be quite relevant to this as well. All these preventative measures, do you feel like burnout is quite common?
I would say, yeah. Unfortunately, one thing that isn't really discussed regarding mental health nursing is, particularly, I think I'll limit this to my experience at Thomas Embling Hospital, is that you'll find the gender mix in mental health is generally a lot different to that in general hospitals. So there's a lot more males working in mental health than there are in general nursing. That's just how it is. I think the field kind of attracts that males. But what you unfortunately find is that if you have to, for example, rely on physical intervention, which you do from time to time, because sometimes there is a point at which certain clients are so agitated and so elevated that you need to use physical intervention to restrain them. Maybe use restrictive intervention such as a seclusion room to manage their behavior, because otherwise they pose a risk to themselves, to others, to staff, to property. So during that time, you can get. I certainly did get a little bit burnt out having to constantly restrain people, and that reliance on male staff members to restrain people. Not to turn it kind of political, but it's when you're working with larger men, you can't expect smaller females that are maybe not as confident to restrain them.
I guess that goes with risk as well. Like it's about minimizing risk for them.
100%, 100%. And I'm not trying to be, gender biased or anything like that. It's just more the practical application of it. If you've got, 110 kilo dude that you need to restrain, obviously you're going to want, you want to do it in as safe a manner as possible. So you want people that are experienced, that are capable of doing so. And unfortunately, males tend to lead themselves to be able to do that more so than females, just to be a little bit non-specific.
What you'd probably say is if you're interested in forensic care, start hitting the gym now and get a bit.
Yeah, pretty much. Yeah, it's and unfortunately, then you get a bit of burnout from that, and then there's burnout on the other end as well. So I mean, again, I don't really like delving too much into genders.
Yeah,
but
that's fine.
I got burnt out because I was restraining a lot, and that's why I kind of made the move to the prisons, because there was a lot less physical intervention involved.
Yeah. I guess to add on to that is, do you feel comfortable talking about an experience where you've had a confrontation with a patient under your care? How did that change you? I mean, you mentioned that there were 3 instances where you've been assaulted.
Yeah. So I guess one of them is the main one that sticks out in my mind was the most serious one, which was in my grad year. And I think this has more to do with my ability to conduct a risk assessment more than anything else. And I was escorting a client to what's called the mental health tribunal. And so essentially what that is they're a body of essentially a judge, a independent psychiatrist, and a community member, and they determine whether or not a client needs to either can be sent back to prison if or they need further treatment at Thomas Embling Hospital, and the psychiatrist will present a report saying that, this patient has done so and so and whatnot. And this particular client wanted to be sent back to prison because he felt he had a bit more privileges in prison than he did in the hospital. And but the outcome of the meeting was that he was to stay at Thomas Embling to receive further treatment because he was quite an unwell boy. So he was deemed high risk from the beginning. So we had two nurses doing the escort there. And that should have raised alarm bells for me, but I didn't really think too much of it because I thought, oh yeah, it's just another escort to the mental health tribunal, will be fine. And but of course, that compounded with the fact that he didn't get the outcome that he wanted. I should have realized that he was escalating in terms of behavior, even though he wasn't necessarily showing it. You could see that, there were certain small signs that he was escalating, that he wasn't happy. And as I was walking back to the unit, he turned around and actually punched me in the jaw, like sucker punched me straight in the jaw. And, that was probably in terms of confrontation, that was probably the worst sort of incident that I was involved in. And, your fight or flight kinds of kicks in a little bit, and, it was a bit messy, and I hit my duress, and, the patient was restrained and taken into the seclusion room and whatnot. And, it was resolved after the fact, but, that was really difficult. But I guess that kind of highlighted to me as a clinician how vigilant you need to be, because during that escort, I wasn't paying as best attention as I could have been. I wasn't paying attention to the signs. I should have been able to see that this patient was slowly escalating and that this could be a potential outcome, because his risk of violence was deemed high. And it was deemed, and that was, as I said before, that was motioned by the fact that I was escorting him with two nurses, and because he was a high risk. So I should have picked up on that, but because I was a bit naive in in my grad year, I didn't. So I guess after that, I kind of learned the lesson to be a lot more vigilant and to do my risk assessments and to continue to do them. I should have done a risk assessment or assessed the level of risk just straight after the mental health tribunal panel, just because I would have then been able to maybe see that, oh yeah, this person is escalating. I need to, watch him and keep a bit better of an eye on him.
I guess one thing, at any point during that, did you ever feel like demoralized, or did you feel like, I just want to drop nursing now, or like, did you ever feel that sort of like sense of like hopelessness, I guess?
Not really. The response from the staff was really good, and I think that's kind of what kept me going a little bit. Like, I sat down, I spoke to a lot of senior members of staff. They provided a lot of kind of encouragement, and they provided a lot of support. So because of that, I never felt demoralized. I didn't feel like I did anything wrong. And
network, yeah.
Yeah, and because of that good support network, I was able to come back to work, within a few days, and I eventually I was fine with it. Really, and the thing is, though, it doesn't really hit you in the moment. Like, immediately after I thought I was fine, I can continue my shift. But once I kind of got home, it kind of hit me that I was assaulted and that this is a dangerous profession, and I kind of thought about what I could do differently and all that kind of thing. But being able to talk to people, that really helped deal with that kind of that negative emotional response that I had. And rationalizing it and then kind of learning something from it, that I need to be a bit more vigilant, that I need to pay a bit more attention sometimes, and I need to be, I need to take my risk assessment seriously.
Yeah, and all that, I think, it goes back to the core skill that you mentioned before, which is risk assessment, for yourself, for them as well. We'll move on to the next question, just because I'm conscious of time. So I guess a lot of people here may be getting placements there, or want to get placements there. So you've obviously been at Thomas Embling Hospital and Marmac, so you've definitely had your fair share of students. So what is the expectation you have for students who might actually find themselves at Forensicare?
Forensicare, like, the mental health placement's fairly unique in that, because of the level of risk that the client population has, we can't unfortunately let you do a whole lot that you'd probably think you'd be able to do. For example, like if you're in Thomas Embling Hospital, you have to be escorted around the unit. Like, you're not allowed to leave the side of a nurse, and that's for your own safety. And or like in the prison, you have to be escorted everywhere because you're what's called a red pass. So you don't have the privilege of just walking around by yourself, and you're not given access to things as simple as the bathroom because you need a thumbprint to get in, just to prevent prisoners getting into that particular area. So it's very it's a very difficult place to do a placement because you are restricted by your environment and you're restricted by this issue of safety. But the expectations I have from my students is that you come in with an open mind. You try to do what you can. You try to learn while there, because there's still a lot to take away from a placement like that. A lot of things such as medication intervention. I know that sometimes medications, particularly in regards to mental health, aren't covered in great depth. So this is a great opportunity to brush up on your your pharmacy subject.
Pharmacology.
Pharmacology, yeah, in regards to mental health. I don't know. Anyway, in regards to mental health. But yeah, so that's a good opportunity there. There's certain actual practical skills that I know I said that you don't do that many practical skills, but things such as blood taking, because you do a lot of monitoring of antipsychotics through blood, so you'll get the opportunity to do that. Doing IM injections, because you give out a lot of what we call depot injections, so they're like weekly or 2 weekly or monthly injections that are an antipsychotic. So we do a lot of those. So brushing up on, I guess, giving depots or IM injections. So there's a few practical skills, but also mental state examinations. That's a big one. So being able to conduct a mental state examination, and even just interacting with your clients in an appropriate manner. Just building that kind of confidence. So that's kind of what my expectation is, and learning a little bit about risk assessment, learning a little bit about the legalities of the Mental Health Act and the Prison Act, and depending on where you are and things like that. So those are my expectations. I would say if you do have a forensic care placement, I'm not sure if you can pick what unit you can go on, but even though acute seems like a good sort of prospect, I tend to think subacute is a bit more suited for students just because you can do a lot more. The patients are a lot more well, so they're able to interact with you. They're more willing to interact with you and tell you about their illness and their journey in regards to their recovery. You have a lot more to do in terms of what's it called? In terms of leaves and things like that, so you can escort them places. Whereas on acute, you tend to be limited due to the risks. You still get to do your mental states, but yeah, you're a lot less independent during those placements.
We'll move on to the next question as well. And again, guys, thank you so much for the questions in the live chat. We will be getting through as many as we can at the end. So in case you feel like it's been ignored, just know that we are keeping notes of it as we speak. So without going into too much details, what are some experiences you won't forget? So obviously, being king hit in the jaw is not something you want to experience outside of King's Cross at New South Wales. But I think, what are some positives, some highs, some lows, and if you feel comfortable sharing, that is.
Yeah, so I guess one of the experiences that I'll never forget is when I first started there, I didn't recept, but I was made associate nurse because you don't get a primary nurse as a grad. For this particular client, and he was a very unwell individual. He had a lot of very bizarre delusions. He was receiving command hallucinations telling him to cut off his leg. He was really quite an unwell individual, and he committed quite a horrific crime. His offense was actual murder. And just seeing him in that state, but I ended up working with him quite closely. And through time, he gained what we call insight into his illness. So he realized that at the time of his offense, he was unwell. Through complying with treatment and working with staff and psychoeducation and things like that. So he eventually gained some insight into his illness, and then I think currently he's on his way out, or he could even be out of Thomas Embling. So just seeing that journey has been something that it made me quite proud to be a part of that, because I saw someone go from this incredibly unwell, possibly one of the most unwell people I've ever seen, to someone who's now a functional member of society. I believe he ended up getting a job, and he's able to sustain himself and contribute back. And unfortunately, due to his illness, he did do something quite serious. But yeah, seeing that journey actually made me proud of him as a patient. And I was happy to be a part of that.
Well, yeah, it sounds like the recovery process is definitely a lot different for individuals that are at forensic care, and like you mentioned, the stay is quite long, so
yeah,
definitely a lot of time to work with some of these individuals.
Yeah.
obviously we won't go into the negatives, but it's good to see that even in a field such as this as well, there are these really
Yeah.
amazing highs as well. And obviously you take the lows where you can, but
Yeah, I guess in terms of another experience that I won't forget, recently I had a fairly confronting one. So, unfortunately you do get to witness sometimes some quite, I guess, the only way to describe it is confronting behavior. So, in the women's system particularly, there's a lot of self-harm behaviors and self-mutilation and things like that. And unfortunately, I was privy to watching a particular client self-harm in a very serious way. And that really does sit with me sometimes. And it took me, I spoke to a lot of people about it, and I needed to reflect on a lot of, I guess I need to do reflective practice on that, because it ended up affecting me in quite a way. So seeing someone self-harm in such a grievous sort of way, like they cut their own throat, and it was a very serious injury, and they nearly died essentially. So like being a first responder to that, seeing that actually happen was incredibly confronting. So, I guess that's another experience that I won't forget, but it has, taken its mental toll on me, and I have had to, talk to people about it, do a bit of reflective practice on it and things like that, just to kind of, I guess, work with it and, avoid any kind of countertransference and things like that.
yeah. And look, I guess when you've got a team, like you said, that you can talk to as well and get that support from, it makes things a lot easier as well.
Yeah.
We'll move to something a bit more light from this. So, which was, I guess a lot of people here would actually be interested in perhaps, applying for forensic care in the future. Now, I know you don't actually do the interviews or anything like that, but how was your application process and, the interview and, I mean, any tips as well? I mean, I think you had a scenario from your interview that you can go through, but just give us a brief explanation of how it went for you.
Yeah, so applying for forensic care, I mean, I guess some tips I could say is try get a placement there, for one. If you're actually genuinely interested in working at forensic care, definitely apply. Definitely try get a placement there, because we tend to, as an organization, I've noticed that it's a bit easier to get a reference check from someone that, a colleague that versus someone who's outside. You tend to trust that reference check a bit better. So that generally gives you a little bit of a one-up. But even if you don't, I mean, don't feel too discouraged. I can't remember what percentage of applicants we had last year that were past forensic care kind of students, but generally it's easier to get a reference check. So that's my number one tip, is try get a placement there. But if you can't, don't feel too discouraged. Attend if unfortunately due to the COVID stuff, you can't really go to the nursing the nursing expo. But if they do one online, just try to attend that. Attend any workshops or the walk around and information nights that you can. And just continue to express your interest. As for the actual interview itself, so the interviews are generally done by the clinical nurse educator, and I believe a RPN3, so someone like myself would sit on the panel and do the interview. And they generally go through things like, what are the core standards of forensic care? They might ask you about a time that you've had conflict and how you resolve that, just your basic sort of interview questions. And then they generally throw in a mental health related question. So mine was a scenario, and it was about, so you've got a patient who's self-harm, how do you deal with that? And I had to, give exactly what the steps I would take if I found a patient self-harming, alert my in-charge, talk to the patient, ask them if they're at risk of suicide, do my risk assessments and whatnot, Yeah, so that's kind of the answers I gave. So it's generally for the interview itself, they'll ask you kind of basic interview questions. Then they'll probably throw in one or two mental health specific ones. And it's generally pretty good to talk about the core values of forensic care, because that, at the very least, it makes it look like that you've put in a little bit of effort to learn about the organization.
So you hear that, guys. Do your research about the place and understand at least, your MSE, your risk assessment, because it seems like those are going to be the big
we don't expect a lot. I mean, even if you might be thrown off a little by some of the questions they ask, but just try to be practical about it and use your head. They're generally not very difficult, but there are a lot of pitfalls in the way people answer the questions, and that's how you kind of weed out whether or not you're suitable for the organization. So, just be a bit smart about it and think about the answer that you're given. Even if you don't know the answer, just try to answer it in a practical sense.
Yeah. The next one. So this is obviously you've talked about, being king hit in your grad year. If you took away that experience as well, what was your grad year like?
Working as a nurse, like working at Forensicare was kind of my first real, I would say, significant job. I've had like other jobs prior to that, but this was the first big one. So I was a bit intimidated coming into it. I mean, I remember on my second day there, my preceptor actually got assaulted. I mean, I speak that there's a lot of assaults, but it's not really the case. These are like, even though I tend to mention them quite a bit, but it's not as violent as I'm making it seem. These moments tend to stick in your mind a lot more. But yeah, on my second day there, my preceptor did get assaulted, unfortunately. But other than that, I did my first rotation. With the Forensicare grad program, it's laid out in blocks, so you tend to do 4 different rotations, and they try to get you an acute, a subacute, sometimes a prison, and maybe a community placement as well. So I started off in male acute. I found it very confronting. I wasn't, I wasn't very good at talking to people. I wasn't very good at conducting MSCs or doing risk assessments. So it was hard. And I did make
that as well, dude. Sorry to interrupt, but if I had to describe to everyone what Daniel was like when he first started to where he is now as well, I'm just saying that there is a huge room for change in terms of the way you speak with people, or just in general, and how you actually practice.
Yeah, you pick up a lot of things over time because your job is essentially talking to people, and as you hone your craft, you get better at talking to people and conducting MSCs and doing that sort of thing. So yeah, I honestly had no idea what I was doing. I believe I made one or two med errors in that time as well because again confidence. But I persisted. I worked hard at it, and yeah, I made it through the grad year. But I would say I learned a lot. What I learned in the first 3 months in regards to mental health, was definitely surpassed what I learned at uni. Like
Yeah.
the knowledge you get on the job is just invaluable.
And just a question we had from the live chat as well is during your grad year, was it all just completed at Thomas Embling Hospital first, or did you also go to corrections facilities as well?
So I did corrections, so it was a bit different because they've kind of tweaked the program a little bit. So
if they've tweaked the program a little bit, we'll just hold off and.
Yeah, no, it's all right. I can answer it because I know what it's like now. So initially, so I went to corrections as my second placement. Now they only allow you to do corrections in your postgrad. So once you've finished your grad year, you can do a corrections placement. Okay. I did do one. I did one through Marmac, which is why I kind of opted to work there again. I really enjoyed it. It's a very different environment. It's very unique. It has its own kind of limitations and its own difficulties and challenges, but overall, it's it's really good. I quite enjoy it.
Well, it's good to hear that the grad year was good, besides being hit in the face. So that's it's always a good sign, honestly. I guess the final question before we kind of move into our live Q&A segment as well is what advice would you give to people, just whether it's general advice or specific advice to people who might be interested in forensic mental health?
I think just go for it. Honestly, just go for it. Like you have to kind of identify in yourself that you're the right person for the job. If you find yourself to be task oriented, that you follow a daily planner, you like routine, it might not be best for you because you might find it a bit too chaotic. But if you're someone that likes to have a bit of banter, likes to have a good conversation, doesn't mind a little bit of madness and chaos in your day, then I would say definitely apply. And I know I keep harping on about some of the negative aspects of forensic mental health nursing, but really these are kind of a small percentage of what happens on the unit. Most days are fairly, I guess, mundane, really. You do your med round, you kind of talk to your clients, you play a bit of ping pong, you do your risk assessments and your MSCs. You might do some paperwork, see where they're at in terms of, in their recovery. But, a lot of the time there isn't this, over kind of hanging veil of violence and whatnot. It's just, those are the kind of the more memorable moments, and those are the stuff that you're always thinking about in regards to risks. But, they generally, for the most part, it's not a daily occurrence, I would say.
I've definitely heard more stories about, competitions of ping pong table than I have assaults. So I can definitely say in that front, guys, there is a lot of positive things around Forensicare. We'll just skip to the live Q&A. So we do have a lot of questions here as well.
Oh, cool.
So Susan originally asked, do you find mental health nursing confronting, or forensic mental health nursing confronting, which we did kind of cover as well. But is there anything you wanted to add on to that, Daniel?
Initially, I found it confronting in the sense of, you do see a lot of things like the self-harm is something that, I struggled with when I first witnessed it, because you do see, watching people disembowel themselves, nearly cut their arms off, light themselves on fire is not pretty, and it plays a mental toll on you. But it comes with the territory, unfortunately. So you're just dealing with that aspect. It was really difficult, but as over time, what you do, you do kind of develop resilience, and through reflective practice, you are able to deal with those negative emotions. So it's you tend to deal with some of the more confronting stuff. I guess the violence also is very confronting as well. But again, it's not an everyday occurrence. For the most part, your job's fairly mundane. It's actually quite fun. Like I really enjoyed going into work when I was at Thomas Embling. Yeah, when it gets tricky, it definitely goes from 0 to 100 like in an instant. But most of the time, it's at 0, and you can generally have some pretty good banter with your clients, and have a pretty good time in your job.
Yeah. So a next question, which is a bit of a shift from maybe the skill or the clinical side of things. Jazz asks, what is the pay like?
Pay is really good.
All right, I won't get you to say how much, but
like
here you
let me put it this way: there's a lot of there's a lot of overtime opportunity. You tend to I think you do get paid a bit more than if you do general. I'm not sure. Don't quote me on that, but you could do. I know of grads that were making into the 6 figures in their first year from overtime. So yeah,
guys, you've heard it here first.
Forensic pretty
care,
sweet.
Mental health nursing, the way to go for money.
Yeah, the pay's sweet. Like my pay this year is like absolutely on fire because I've done tons of it.
Don't say anything specifically. Don't give too much away, otherwise people will be leeching off you in no time, myself included.
But yeah, no, the pay's good.
Another good question from Susan is, do you deal with addiction and substance abuse as well? And how is it kind of dealt with by Forensicare?
I would say we deal with this. Yeah, yes, like 100% we do. It's just one of the facets that unfortunately comes with this client population. I would say I deal with it more now in the correction setting than I did at Thomas Embling. So Thomas Embling, because generally you got the more acutely psychotic patients, substance issues were more kind of put on the sideline. So you were more trying to treat their psychosis rather than dealing with a lot of their psychosocial factors and substance use. Whereas with in corrections, because you tend to not get as many. You're not looking after the population isn't as acutely unwell. It's not to say that they're not acutely unwell, because you do from time to time get some really unwell clients. But for the most part, substance use is a lot more prevalent in that population, and it's a confounding factor to a lot of behaviours such as their offending, and their illness. Even you tend to find that a lot of people deteriorate in the context of substance use. So what we tend to do is we tend to promote, I guess. We don't promote abstinence as such. We tend to promote the harm reduction model. So just letting them know of the risks of, for example, if they're going to be released, of the risks of recommencing substance use on release and things like that. Just making sure that they've got all the education, and it's generally up to them otherwise to make that decision. But you try to provide them with the information, the tools to succeed. You might refer them to a rehab clinic if they're available, but unfortunately, just due to the public system, it's very hard to get into at this time. There's long waits for everything. Or you try to get them linked in with drug and alcohol workers in the community, or in area mental health. So you try your best to kind of address their needs, but a lot of the time it's up to the individual. And I find that it is up to the individual to make that change. And sometimes they're successful, they want to stay clean and they do. Other times they're just, it's so ingrained that they just, as soon as they're released, they go off and use substances. And but we try to promote harm reduction though. So if we tell them, if you're going to go out and use substances, to take it easy, because their tolerance would have decreased during their incarceration. Because what you'll find is, I think there's a statistic, something like 40% of people that got opioid users particularly, don't quote me on the actual number, but I believe it's around 40 or 50%, end up overdosing within the first 2 or 3 weeks, just because they kind of neglect to the fact that they've become, they've lost their tolerance to the substance, and then they use, and then they unfortunately, they end up either seriously ill or even dying. Like that has happened.
Yeah.
So it's, we promote harm reduction, and we tend to we try to put in interventions in the community once they're released. This is from the prison setting, and we try to just give them as much education as possible.
Yeah. I mean, especially given the climate now, it's probably becoming
Yeah.
a much more, topical issue in terms of substance abuse.
Yeah.
Our next question is a bit of a difficult question to answer. And I suppose this will kind of depend on the patient that you are dealing with, whether or not it's a personality disorder or anything else, which is, do you find that consumers are faking it sometimes?
Oh, so the term for that is called malingering. So
Yeah.
malingering means that they feign illness. Yeah, I have seen it. The thing with that is, if you think about the setting that they're in, right? So they're being watched essentially 24/7 by mental health clinicians, and you have to be some actor to be able to keep that up for periods of weeks, if not months, or even years. You know, so what you tend to find is a lot of people don't malinger as much as you think. And
Yeah.
it's pretty easy to pick up when someone's malingering. It's not to say that it hasn't happened, we haven't been completely fooled, but I like to think that feigning psychosis is a lot more difficult than you think. It's a lot more difficult than saying, "Oh, I'm hearing voices and seeing things." There's certain patterns of behavior. There's certain kind of tells that you can see that, I don't think this person is unwell, or oh yeah, I think that person is actually legitimately unwell.
Yeah.
So yeah,
Obviously, that's a very difficult question to answer because it would be on a different case by case basis. But
yeah, it all depends on the individual. Like I've had people that I think have malingered, and I've highlighted that to the psychiatrist, and he's agreed with me. Whereas other times, the thing with psychosis is it's so hard to mimic because there's kind of this disorganization that is one thing that I find people who malinger can't quite grasp is the disorganization in behavior and thought that is so profound with psychosis.
mm,
And if you can't really, yeah, people just I haven't seen anyone grasp that concept.
um, yeah, the next question we have here is from Alec, which is, we kind of touched on burnout, but do you feel that the burnout was better or worse at Thomas Embling than at Marmac, or what do you feel has been, I guess, better for you as a person?
The move to Marmac was definitely a good one for me because I was getting burnt out in the male acute unit just because I was being on the front line constantly really plays a toll on you.
Mm,
Going to Marmac has its different kind of, I guess, factors in regards to burnout. There's I guess a lot more self harm here that I'm not used to, so it's just kind of dealing with that on a personal level.
mm,
Whereas in Thomas Embling, it was more fearing for safety of yourself or your colleagues, because it's not nice seeing being assaulted or seeing your colleagues get assaulted constantly either.
mm.
So, but yeah, there are different kind of factors contributing to burnout. But I find the change to Marmac was, it's given me a kind of a second wind in terms of like my career. I'm definitely a lot happier doing what I'm doing there in Marmac now, just
Yeah.
because it feels kind of fresh, it feels kind of new, even though there is this kind of different, I guess, stressor there.
Yeah, the next question we have is a much more lighthearted one from Claire, which is, what are the main things you love about your job, or what do you love about your job?
I just I like the banter essentially, like being able to just go out there and talk to my clients. It's like you you're in a unique position to talk to some of the most experienced people out there, and some of the stories that they can tell you and things they've experienced and seen. It's amazing. It really is. Like I just love sitting down and talking to people, and talking about their lives, what they've been through, what they've seen.
Mm,
So, the banter is definitely the best part of the job. And not only that, the staff as well, like especially with, a supportive staff and, staff that you can also share some banter with. It's a fairly, I find that, the units that I've worked on have been fairly lighthearted. You get along quite well. And there's also like a social aspect to it. You do go out for drinks after work and things like that. And you do hang out with each other, have a barbecue at your colleague's house. So there's a really good social aspect to it. But the thing that gets me back to work is the stories. Like you look after some very interesting characters that have some amazing stories, and sometimes their behavior is quite funny as well. So the amount of stories that you get out of this job is amazing.
mm. We got a few from Josephat as well, which the first one is, so this was on the topic of like the violent patients as well. So um, I think the first part of it is, are violent patients placed in seclusion rooms when they escalate?
So it depends on the setting. So in in Thomas Embling, we use seclusion as a means to help manage behavior. So if that if they're a risk to themselves or to someone else, then we may need to use a physical intervention such as seclusion to manage their behavior. So yes, violence can be managed with seclusion, but it's privy to the fact that it has to be a last resort. So we don't like to use it, but we do use it at times. But in jail, the seclusion rooms are not called seclusion rooms. They're called Muirhead cells, and we use it more to manage self-harm behavior.
Yeah, and I'm assuming there's a lot of policies around seclusion.
Yeah.
But like you mentioned just before, it is a last resort.
Yeah, so I guess the key aspect to take away from that is that seclusion is generally a last resort.
Yeah. Another question from Joseph is, talking about the rate at which staff are injured. So I guess at what rate are staff injured by aggressive patients? You mentioned it's not a real frequent occurrence.
Unfortunately, I'm quite unlucky that I've been assaulted 3 times, but I think I'm the only person in my grad year level that ended up being assaulted. Or I think there's only a few people in my grad year level that have been assaulted. I mean, it isn't as high as it, I'm making it seem, just because, my stories tend to revolve around physical altercations. But it's definitely a risk that is present in the workplace, but you don't go to work expecting to be assaulted, and you generally don't have an incident. You might have an incident once every week or 2 weeks, if that. Sometimes you go for months without anything happening. So it all just depends on the population and the client base.
Yeah. So this was, again, talking about the physical intervention. So you talked about a lot about physical interventions for aggressive patients. What are physical interventions for those who might not be aware?
So physical interventions, they refer to, I guess, any kind of hands-on approach to a patient. So they might mean something as simple as sitting down and restraining them, using restraining their limbs so that they don't assault you, or just using a seclusion room, for example, as a physical intervention, using handcuffs if they're being transported somewhere. That's considered a physical intervention. So that requires specific paperwork and a form called the MHA 142. So that's the Mental Health Act form that says that a psychiatric nurse or a doctor or someone allows for the use of physical intervention. So if handcuffs, restraining them by holding them down, putting them in a seclusion room where they can't actually be let out, is considered physical restraint.
Yeah, and so the next question is from Danielle. So we did kind of answer it, but just so we can address it. Do forensic care often rotations during graduate correctional facilities, or do you need to complete 12 months? I believe you mentioned that you.
Yeah, so 12 months. So to go through corrections, you need to they're available for your postgrad students, just because originally working, because you're a bit more autonomous in the prison setting. It used to be that only RPN3s could work there, so your ANOM level nurses could work in the prison setting, and that was more due to the level of risk, the risk assessments that you had to do, and I guess your autonomy that you have. You're essentially a lot more responsible in that setting than you are at Thomas Embling, where you have a team to work around. But now they're allowing RPN2s to work in the prison setting alongside RPN3s. And once you move from a grad to a postgrad, you go from an RPN1 to an RPN2. So in that sense, you can actually work in the prison setting. And you are offered rotation. So you can either go to Ravenhall, MAP, or Dame Phyllis Frost, or I believe there's, what's the other one? Port Phillip as well.
The next question is quite a big one. I think a lot of people have when they think about when they do talk about pursuing mental health as a career in nursing, is what happens to your general practical skills? What do you think happens to them? Because obviously you haven't. Really
I would say honestly, you do de-skill. Like, I'd like to think that I wouldn't. And initially when I went into it, I thought, no, I wouldn't de-skill. I remember all this stuff. But the reality is you do. But the thing is you de-skill in terms of a lot of your general skills, but you gain a lot in regards to mental health and de-escalation. So I'm a lot more comfortable dealing with, someone that's ranting and raving and screaming than I would be dealing with someone that's, hemorrhaging. I really, dealing with physical health really kind of, it unnerves me a little bit. Whereas if you've got a violent, kind of patient that's gone haywire, like I'd be more comfortable dealing with that.
Yeah.
But yeah, you essentially replace the skills that you have in terms of your physical health with mental health related skills, and you build upon those. But you do still use some of your physical health stuff, as I mentioned. There's certain medications that require active monitoring, so you have to know how to do OBS. You have to know how to take bloods. You have to know how to give IM injections. So there's still certain practical skills that you need.
Yeah.
But it's just, like things like putting in catheters or, drainage tubes and stuff like that. I mean, you might get the odd patient that's come in with that particular physical ailment that requires that level of intervention. But for the most part, like you do lose those skills.
Yeah.
Unfortunately.
The next question is from Lauren. So Lauren's question has a few things that I'm not too familiar with, but hopefully you understand, is how many P1s would you have at DPFC at any one time?
How many P1s? So this person's obviously done a rotation through corrections because that's the only way they know.
Yeah. So do you mind explaining what that is?
So a P1 is anyone that's deemed, I guess, so you have a P in prisons, you have certain ratings. So P rating refers to a psychiatric rating. So if they're a P1, that means that they're what's the wording that they use? They use a specific wording for it, but they essentially they're acutely unwell is the gist of essentially what it means. So I guess everyone that comes into Marmac is a P1. But in reality, you can have an infinite number of P1s in the sense that if everyone's deemed unwell and suited for Marmac, you're not limited by the number of beds on Marmac, even though you just identify that they need to come here and you make them a P1. But for the most part, I would just say 20 because 21, because that's how many beds we currently have on Marmac.
Yeah.
But they can be more than that pending admission to Marmac.
The next question is from V, which is, are there any particular skills or any particular experiences that you've had, outside of nursing that has definitely helped you become a better mental health nurse? So you mentioned a bit about, experiences with friends and things like that, but
any experiences outside of work? I think working, and I used to be a debt collector at a call center, so I copped a lot of abuse, and just developing that kind of thick skin, because you do tend to get that makes sense to your partners. It works CV at math. Yep. No, that makes a lot more sense. But yeah, so I think being able to have a bit of a thick skin is definitely a skill to have. So if you worked retail, if you've worked, in one of those jobs where you might be abused, that, it kind of helps you develop that resilience, I guess. Otherwise, just as, I guess, being a personable person, really, being able to talk to people, carry conversations, because a lot of the time, I think, actually, this reminds me of something that I noticed students struggle a lot with, and that's asking questions. And it seems like such a basic concept, but it's something that I observe time and time again, that, simply conducting an MSc and asking some of the harder questions like, oh, do you feel like killing yourself, or do you feel like committing suicide? Have you ever felt like committing suicide? Those sort of risk issues, I find that students tend to get very nervous asking them, or even asking about their mental illness, and sometimes, they're a bit too direct, or they're not confident enough, and you might not get the answer that you're after. Whereas, over time you develop the skills to ask these questions in different ways to get the answers that you need. Because you might not necessarily approach directly. You might kind of, have a bit of banter, have a bit of a conversation going, and then go on to it. Or you might kind of in a roundabout way ask, hey, do you still hear the Queen talking to you at night, or something like that? You might make reference to their psychosis. And the thing is, again, you develop those skills over time versus, you're not expected to know that sort of stuff. But I find students do struggle with that, asking questions.
Yeah. So a few extra questions as well. And guys, thank you so much for asking so many questions as well. We're just going to answer the ones that are there now, and then we will be concluding the presentation. But we'll go a bit more into detail with those later. So the next question we have is, the difficulty of getting a job in forensic care. So obviously you mentioned that you did get your grad year, and you did have placement there. But in terms of people who, might not be fortunate enough to get that placement, or might not be fortunate to get that grad year, do you feel like there's still the ability to get a job at forensic care?
Yeah, 100%. It's more to do with the interview. So it's 100% to do with the interview versus that. I mean, it just helps that, we're able to put in a good word if you have done a placement, but it's more so how you present yourself at the interview. I would say they're ever expanding the grad program. So I think now they take 20 grads as they used to. When in my year level, they only took 10 grads.
Yeah, it's a lot more, yeah.
Yeah, so they've doubled the grad intake just because they're expanding the service. And the thing is, forensic care is quite a niche field, so you don't get as many, even though there's less kind of positions to apply for. Well, I can't remember if it's 20 or 15. Anyway, don't quote me on that one. But yeah, because it's a very niche field, you don't get as many applicants for it, and people tend to be put off by the fact that it is forensic mental health nursing. So it attracts it attracts a certain type of person.
Yeah.
And so the competition, I guess it's hard to say because you're getting less applicants, but the people that do apply tend to want to work there and tend to put in the effort to try to get a job there because it is so niche. But because if you think about it, it's like a specialty field within a specialty field, because you've got mental health nursing, which is your specialty field, and then you've got forensic mental health nursing, which is another specialty field on top of that.
Yeah. The next question is a pretty quick one. Do you reckon there's a shortage of mental health professionals? And do you think that there'll be more demand for it as we move forward?
Yeah, 100% is like the amount of overtime you do is just insane. It's absurd.
And that's partly just due to shortage of staff.
Yeah, just shortage of staff. People. It's not, again, it's because it's such a risky field. Like, people tend to be put off it. Not only that, when people they do their nursing, they think more like peds, or they want to work in what's it called? They want to do, I guess, work in general, essentially.
Yeah.
So not a lot of people want to become mental health nurses compared to all your different fields in terms of general.
Yeah.
But yeah, so and given that the whole, I guess there was that what's it called, the inquiry, the mental health, what's it called, the Royal Commission on the Mental Health in Victoria recently, and all that kind of stuff. That's I believe that kind of identified that there was a need for mental health clinicians, so they will be opening up new positions. I can't remember I can't quite remember the funding allocation, so there could be a lot more positions coming up.
Yeah.
Just as a result of that, a direct result of that, and identifying the need for mental health. So
the next and probably final question, so we unfortunately are cutting it off here, which is, how do you control your fears of confronting a violent patient? And does it get better with time?
Lots of value. No, I mean,
lots of
no, it's just you kind of get used to it. I like when I first had to de-escalate a patient, I was mortified. I was so terrified. And, it's a natural kind of emotion that you experience. And it would be the same for nearly everyone, No one, because if you're not terrified, you're overconfident. And if and you don't have the experience to deal with that situation, to be that confident. So, I was terrified. But over time, as you tend to, they generally don't let you loose to de-escalate a violent patient or an escalating patient. They generally have someone with you to make sure that, to have you back, so to speak, in case things go a bit awry. But for the most part, it's just, I was scared shitless, to be honest. But you build the skill over time, you do it a lot more, and you become a bit more confident. And it's just, you just have to remember simple things like treat the person as a person, be respectful, and do simple things like identify what they're angry about. A lot of the time people are so quick to contain behavior, they don't sit down and actually ask, hey, why is this person angry in the first place?
Yeah.
Because a lot of the time it could be something as simple as, I didn't get my sugars with my meal. And then it's a simple fix, like, here's your sugars, don't worry about it, man. Like, just identifying what the need is, and then
going from there. And I guess it's an ever evolving process in terms of learning skills as you go on forward. And guys, that will wrap up our live Q&A. So firstly, I would like to thank Daniel for taking the time tonight and actually going through this. This won't be the last we see of Daniel as well. Daniel has been more than happy to volunteer his time in the future as well. So we are going to have reoccurring segments with him regarding Forensicare. And we do have a few other of his colleagues that are also interested as well. Just one thing as well that I do want to address as well. We do have a next event as well. So obviously, Daniel, this is not you're not a pediatric nurse, but in 2 weeks...
I know nothing about pediatrics, mate.
We are going to be implementing another session similar to this with a pediatric nurse. We are expecting it to be bi-weekly, so we are expecting this to happen in about 2 weeks' time. However, we encourage people to follow our socials and Facebook and Instagram. So that's on the next page here. So thank you everyone for attending as well. So again, follow us on our socials and follow us on Facebook as well. We will be announcing another event similar to this as well. There will be a live Q&A component and also a normal questions answered in advance as well. So we really do encourage everybody to get involved as well. Shoot us a message as well, share us around if you can. And again, thank you everyone so much for coming as well. It's been an absolute pleasure to be here. And Daniel, I hope you've enjoyed your time here as well. And I really do thank you for coming out today.
Yeah, cheers. No, thanks everyone for attending. I'm glad I could kind of spread a little bit of knowledge about the field. But yeah, cheers. Thanks everyone.
No worries, guys. We'll be concluding it here as well. And with that, again, thank you again. And we'll be closing the Zoom call now. As Facebook will share the YouTube link as well. So we'll be planning to upload that within the next 2 days. Once that's uploaded, we'll share it straight away. And you guys will have access to that as well. Thanks, guys, again, and enjoy your night.